Hello there, I'm Tony Meekum, and this video is systemic diseases that affect bone. So we're not going to cover all of them. There's a lot of diseases that touch skeleton, and most of them are going to be someone else's problem. So we're doing the ones that show up in the jaws often enough that you should be able to recognize them on a panoramic radiograph. And I want to set expectations right away because this topic has a reputation for being memorization slog. It doesn't have to be that way. You're not going to diagnose hyperparathyroidism from a radiograph. What you're going to do is notice that something's wrong with the patient's bone, describe it accurately, and know enough to say what family of disease it belongs to and what to do next, who to refer it to. That is your job. So here's the organization, and worth pointing out that this deck is organized by mechanism, not by alphabet. 8 system pathways: the calcium, vitamin D, and parathyroid hormone axis, which gives us osteoporosis, hyperparathyroidism, hypoparathyroidism, Rickets, Osteomalacia, renal osteodystrophy. Then our alkaline phosphatase, which we'll talk about Pagets, and hypophosphatasia. And then osteoporosis, which is an osteoclast problem. Then the growth hormone diseases, then thyroid, glucocorticoids, collagen, and the anemias. So grouping them this way is what I think makes it learnable. You know what system's broken, then the radiographic changes stop being just random facts and more consequences of what's causing it. All right, quick note on the scope, because I've deliberately trimmed this. We're going to touch on the vitamin D, calcium, and PTH relationship, just enough so you can read the labs and understand why bone looks the way it does. I might focus on just a couple of labs that you need to know, but we're not deriving pathways, the full mechanism. That's going to get developed in the bone healing and pathology block of the skeletal muscular course. And so no reason for me to do it twice. And so I want you to do from here on is one thing. Think of what this disease looks like on a radiograph and how you describe it. That's kind of the main purpose of this whole thing. And then this slide is going to be the backbone of the entire video. So let's spend a minute. Systemic diseases can only do a limited number of things to bone. And this is the list right here. So in the jaws, you can change the shape and size, a change in the number, size, orientation of trabeculae, altered thickness and density of the cortical structures, and then an overall increase or decrease in density, which leads to a radiolucency or radiopaque appearance. In the teeth, you can get accelerated or delayed eruption, hypoplasia, hypocalcification, and then potentially a loss of a distinct lamina dura. One critical caveat on the dental findings: changes to teeth themselves have to take place during tooth development. So if a patient develops a metabolic disease at age 50, is that going to affect their teeth development? No, their enamel is going to be fine. Enamel was finished decades ago. That single fact is going to solve several problems for us later, including one in the next few slides. So here's your description checklist for every case in this video: size, shape, trabeculae, cortices, overall density of bone, how it affects the teeth. Run through those 5 and you'll produce a competent description of a systemic bone disease, even if you have no idea what the disease is. So let's get started with the most common, which is generalized osteopenia. If you've been at clinic at all, you've probably seen this. So look at this image against the checklist. Look at the trabeculae size. The normal trabecular pattern is lost. There's a heterogeneity and a thinning of the normal inferior cortex of the mandible. As you can see here, it's lost that nice thick cortex that you usually see. And then what do you notice about the teeth? Well, the teeth themselves don't really have any malformities, but they kind of stand out against the bone. They're really prominent. And that's because of demineralized bone. That contrast effect is going to be a recurring theme here. So when bone loses density and the teeth don't, the teeth are going to look unnaturally bright. Osteopenia is a finding, not a diagnosis. And it's worth keeping in mind that other things produce it. Hyperparathyroidism, leukemia, lymphoma, multiple myeloma, a lot of these things can cause an osteopenic appearance. I will point out really quickly while I'm here, a couple unique things about osteopenia and potentially osteoporosis is the external oblique ridge stands out. I will point out as well, I've already pointed out how you get thinning of the inferior border of the mandible, but the external oblique ridge also becomes very prominent. And so here's the loop. I'm not going to walk through every arrow, but pay close attention to 4 values as we go through the diseases, because those 4 are what you might be asked on a board question. So calcium, PTH, phosphorus or phosphate, which is labeled PI on this graphic, and then alkaline phosphatase, which we'll get to shortly. So one vocabulary note, since it tends to trip people up: phosphorus combined with oxygen is phosphate. And that's the form that it's in usually in the body. It's central to cellular energy. If you remember ATP, that's where phosphates are going. All right, so this is going to show you the function of vitamin D. Just that last chart kind of blown up as we can hone in on one thing. So what does vitamin D do? It promotes calcium and phosphate absorption in the intestines. That's the headline one. It increases bone turnover, so bone resorption. It self-inhibits, shutting down 1-hydroxylase in the kidneys, and it inhibits PTH production in the parathyroid glands. So here's the part that seems contradictory until you see it clearly. Vitamin D increases bone resorption, but you usually think of vitamin D as being good for bones, right? But it's also required for bone mineralization. So both are true. One dominates depend on the plasma calcium level. In a hypocalcemic state, vitamin D and PTH together are going to pull calcium and phosphorus out of the bone to prop up blood levels, because blood levels are where it's most important. But in a normal calcemic state, vitamin D is what allows calcium to get deposited in the osteoid matrix and epiphyseal cartilage. So vitamin D isn't pro-bone or anti-bone, it serves serum calcium, and it will build bone or dismantle bone depending on what the serum calcium needs. So hold on to that, because it's the same logic that drives PTH. Now, parathyroid hormone, it has one priority in life, that's serum calcium. It is relentless about it. It increases bone resorption to raise serum calcium. It increases calcium resorption in the kidneys. So it increases bone resorption to raise serum calcium. It also increases calcium reabsorption in the kidneys while dumping phosphate. So it promotes hydroxylation to active vitamin D in the kidneys, and the loop closes because increased serum calcium reduces PTH production. And why is the body so aggressive about calcium? Well, because the consequences of low serum calcium are immediate and they're ugly. Hypocalcemic tetany, and on the neurology side, confusion, memory loss, delirium, depression, hallucinations. So bone gets treated as kind of a calcium reservoir. The body is going to strip the skeleton to keep blood calcium in range, and it pays for it in phosphate, which goes out in the urine. I always think of a trade-off between calcium and phosphate. You're trying to hold on to as much calcium you can at the expense of phosphate. So two things are going to follow from this, and that will also pay off in the table later. So first, kidney reabsorbs nearly all the calcium that enters the glomerular filtrate. Second, the kidney has to be working properly to excrete enough phosphate. So think of calcium as scarce and hard to hold on to, and phosphate as being abundant and need to be dumped. So when kidney function fails, that second half breaks and phosphate actually climbs. For completeness, calcitonin comes from the thyroid and does the opposite of everything PTH does. Think of kind of toning down the calcium. It increases bone mineralization, so taking it out of the blood serum and into the bone. And it also increases calcium excretion. So calcitonin tones down serum calcium. All right, so on to our first real metabolic condition here, Rickets and Osteomalacia. These are the same disease, just at two different ages. Both are manifestations of vitamin D deficiency or abnormal vitamin D metabolism, and both come back to the fact that you need vitamin D for normal calcium absorption in the GI tract. Rickets is in children, where deficiency interferes with deposition of bone at growth plates. In the first 6 months, tetany or convulsions are a common presenting sign. As the child grows, there's not enough mineral going into the growth plates, epiphyseal cartilage overgrows, and you get these classic bowed legs that we see in this image here. It also hits the skull, giving frontal bossing, and the ribs, giving potential pigeon breast. So osteomalacia is what we call it in adults. Decreased bone density and predisposition to fracture. Radiographically, it can look just like any other cause of decreased density. So in this case, you're seeing increased radiolucency in the alveolar bone around the teeth. The teeth look okay, but where's the lamina dura? Where's the normal trabeculation? So outside the mouth, the finding is fractures and microfractures, also called pseudofractures or looser zones, most commonly in vertebral bodies and femoral necks. And distinguish this from osteoporosis, because the two get conflated. Osteoporosis produces porous, brittle bone. There's less bone, but the bone that's there is still properly mineralized. Osteomalacia produces soft bone, so there's a normal amount of matrix, and it isn't mineralized, so brittle versus soft. All right, what do you think in this question? Give you a second to think about that. Commit to an answer before I give it away. But the answer is Rickets, and the reasoning is the rule from slide 4. Look at the teeth. The enamel and the dentin are affected. And teeth are only developing when we're children, right? And so the adults have finished their tooth growth. So if tooth structure itself is abnormal, the insult happened during development. Now a caveat, because I don't want you overcommitting, this particular image looks like it could be amelogenesis imperfecta type 1. So an appearance like this could be a genetic enamel disorder, or it could be a nutritional deficiency or any other disease that inhibits mineralization of tooth structure during development. Radiographic appearance narrows the timing, not the specific cause. And so aside from the maldeveloped enamel, we may have delayed eruption, malocclusion, dentin defects as well as enamel. And with those defects, with the defective enamel comes increased caries. In adults with osteomalacia, the teeth are already built, so the disease only shows in bone. Overall radiolucent appearance, sparse trabeculation, thin or absent lamina dura, and clinically adults with osteomalacia may have bone pain. All right, on to hyperparathyroidism, and this is a big one I want you to remember. Know it cold because it produces the most distinctive picture in this entire video. Too much PTH means what? We said the main priority PTH is maintaining levels of calcium in the serum, and it does that by drawing calcium out of bone. So relentless bone resorption if it's too high for too long. Demineralized and thinning of cortices everywhere, overall decreased density, ground glass internal appearance, and that's somewhat unique. I wouldn't say it's pathognomonic for this, but when you have that generalized ground glass appearance, it's because of this in a lot of cases. And That should lead you at least first to think of hyperparathyroidism. And then also brown tumors, which resemble central giant cell granuloma or aneurysmal bone cyst, at least as far as the histopathology goes. But what we're going to see is overall decreased radiolucency, maybe this salt and pepper appearance, and you may see some of these solitary bone lesions that in the presence of hyperparathyroidism we're going to call brown tumors. So did you notice the difference in appearance of this skull here? This just generalized ground glass appearance. Usually you see marrow space in here. You usually see a definitely pronounced outer and inner table of the skull, but the internal pattern is completely granular, and there's generalized lack of a defined outer cortical boundary on the osseous structures. The bone has essentially lost its edges, including here throughout the skull base, throughout the spine, throughout the maxilla, and the mandible. Does something stand out about this panoramic image specifically? The contrast effect again. Look at the teeth. Look at how they stand out against the bone. I think that's the most recognizable thing about what we're seeing with this image right here. And so the jaws go radiolucent while the teeth stay radiopaque. So teeth really stand out dramatically against the bone. Let's go back to here. In the periapical finding, what do we see? Loss of a distinct lamina dura, maybe some radiolucencies up in the periodontal region. But what do you notice about the trabeculation? It's lost that. It has this granular texture to the bone pattern rather than the normal trabeculation. And then in the CT, showing the same thing, loss of that trabeculation. But what's this likely? If you see this generalized ground glass appearance and some large expansile but well-defined lesion, probably going to be a brown tumor of hyperparathyroidism. So sometimes you'll see features of central giant cell granuloma, and in fact here we see some of those wispy septae. It is well-defined and round and very expansile, similar to a central giant cell granuloma. But a lot of times the bone is just so radiolucent, you lose some of those signs and it's tough to see the cortex. And so the practical takeaway is this: if you find what looks like a giant cell lesion, hyperparathyroidism belongs on your differential, particularly if they have this generalized ground glass appearance. And then a serum calcium and PTH is going to sort it out. A giant cell lesion is a local problem, but a brown tumor is a systemic problem wearing the same cap. All right, so if you see this image again, is it going to stand out? Are you going to be looking around and saying, okay, where are the sinus borders that Dr. Meekum always told me to look for? They're not here, but they're missing on both sides, and there's this overall change to the bone structure. As long as you look at this and think there's something systemic, maybe if you appreciate the ground glass appearance, you might go to hyperparathyroidism. But as long as you're leaning towards systemic and more information needed, that's where you need to be as a dentist treating these patients. Okay, I already mentioned these, but brown tumors in a little more detail. They're lesions made of osteoclasts, reactive giant cells, and hemorrhagic debris. They're both radiographically and histologically similar to giant cell lesions. The mechanism's straightforward once you say it out loud. Bone loss predisposes to microfractures. Microfractures bleed. Hemorrhage draws in microphages and reparative fibrous tissue. That mass of reactive tissue is going to be the brown tumor. And when it goes systemic and severe, you get osteitis, fibrosa, cystica. That's a great board term. I see it come up over and over on review material. So grossly thin cortex, increased fibrous tissue with foci of hemorrhage and cysts, widespread multiple lesions. The combination of increased bone cell activity, paratrabecular fibrosis, and cystic brown tumors is the hallmark of severe hyperparathyroidism. All right, on to the next pathway. Alkaline phosphatase, ALP, is what you'll see it referred to in most cases. So ALP is an enzyme that removes phosphate that makes it available for bone mineralization. This is released during osteoblastic activity, so it has a lab value. It's a marker for how hard osteoblasts are working. It'll be present throughout the body, but concentrated in the liver, bone, kidney, placenta, and that's why it goes up in liver disorders as well as bone disorders. And the big one to memorize, I've already mentioned this before, but ALI is highest in Paget disease, higher than any other disorder. Common board question there. But keep in mind, it may be elevated in some of these other diseases: Rickets, Osteomalacia, hyperparathyroidism, multiple myeloma, metastases to bone, and even fracture healing. So anything where there's a lot of bone turnover, it could have high ALP. It's just when it's Paget disease where it's off the charts and everything else is pretty much normal. And speaking of this, we already covered it in the multiple radiopacities lectures, so let's hit on it really quickly. This is abnormal osteoclastic activity, which leads to increased resorption, and that's followed by disordered bone formation. The result is bone that's structurally unsound. And there are three typical stages that kind of overlap: the initial osteolytic stage, meaning it's resorbing bone, it looks radiolucent, then a mixed osteoclastic and osteoblastic stage, and then the final burned out osteosclerotic stage where bone is dense and radiopaque. So more common in males. And then the tibia image shows the other half of the disease. The bone is bowed and large, sclerotic. Here we can see it progressing over time, and there's thickening of both the cortical and the cancellous bone. So that's what structurally unsound looks like when it has to bear weight. So most cases of these are asymptomatic and found incidentally on a radiograph, which is why it's relevant to us. When there's pain, it's often from microfractures or from bone overgrowth compressing nerve roots. And in the less than 1% of cases overall, though 5 to 10% of severely polyostotic cases, you can get secondary osteosarcoma. Classic history is that the hat doesn't fit anymore, the skull is enlarging, and that's why. And then this is important for the radiographic appearance here. The descriptor you need is cotton wool. Look at that lateral skull image. Does that just look like tufts of cotton to you? That flocculent cotton wool appearance with substantial thickening of the skull bones is classic for Paget's disease. This is what it looks like in the jaws. It's relatively rare to affect jaws, but when it happens, it favors the maxilla over the mandible. We said that that was 2 to 1 on the previous lecture. Then the clinical tell for us that parallels the hat is the denture. The denture doesn't fit anymore. If a patient tells you that, and there's no obvious local explanation, it's probably worth pursuing. And as I mentioned before, it's associated with hypercementosis and osteomyelitis because Paget's bone is poorly vascularized and doesn't handle infection well. And so what was the big lab value you're going to remember with this? That's extremely high ALP with serum calcium, serum phosphorus are going to be normal. All right, quick meme for you, dentist meme for you here. My dentist says, it's not brain surgery until you slip. Keep that in mind. Try not to slip.